So some background, we know that in 2017, about 356,000 cardiac arrests occurred, with a majority of those happening in adults. The initial shock rhythm was 18%. This is something that has been decreasing over the years. And out of hospital cardiac arrest survival to discharge is about 10.4%. Some people in the Northwest have a little higher rates, again, based off some of the things they're doing. And survival with good neurological outcome or good functional status is about 8.4%. We'll look at the phases of cardiac arrest. I think this is something that we need to discuss and the interventions that's going to be associated with each. So I think when we initially look here, we see that we have the collapse phase is time 0. And from collapse to about 4 to 5 minutes, we're going to have the electrical phase of cardiac arrest. And usually this is going to be a ventricular fibrillation. And this is where you're most likely to be able to defibrillate these patients. Good thing for most of us, if you're practicing ICU or you get patients that code on you in the ED, again, we're most of the time around when this happens. So that's going to be great. For the vast majority, from 5 to 10 minutes, going to be the circulation phase. And that's where you're going to have to do a little bit more chest compressions to build up enough perfusion to get your shock rhythm again and defibrillate them. And then for a large percentage of patients that are coming from out of hospital, especially in the ED, again, we're going to be getting these patients in the metabolic phase where they're going to be having active chest compressions ongoing, but there's a host of other things that are going to be happening during this time frame. And we've always been discussing whether there's some new therapies for cardiac arrest, with hypothermia being in and then being out as of recently. There's some interest in research in apoptosis inhibitors, antioxidant, and cardiac bypass. Again, ECMO being something that we can consider. So looking at the etiology, it's a host of things. And I think this is something that we know that occurs frequently in the cardiac component, where you're going to have either some type of arrhythmia or some type of myocardial pump failure. Hypothermia is another one that we get quite often now. Massive hemorrhage, respiratory failure, electrolyte derangements, and drug toxicities or overdose. This is a pretty interesting chart here, and I'm going to orient you guys to it. So this is going to be the percentage survival rates after out of hospital cardiac arrest, and this is going to be over time. So I want to start from the top because this is going to have the highest amount of survival, and bystander CPR is going to be the best thing we can do for our patients out of hospital cardiac arrest. And then survivable first rhythm is shockable. Again, it's going to be getting us from 25 to close to 32%. As we go down, we see that survival EMS treated, again, those patients are in the 10 to 15%. And then lay use of AEDs, again, something that's been increasing over the years from 4% over 7%. But again, we're going to see the lowest amount of patient survivals there. And the big thing we've been doing over the different iterations of our guidelines is getting the lay public more involved and getting the lay public to understand what's going on and giving them access to AEDs, giving them information on how to do CPR. You can perform CPR in the airports now. So that's something that's pretty interesting. So I mentioned it very briefly. Just another way to look at it is that you can have predictors of survival is CPR by bystander, which is obviously one of the most important things to have a decrease in low flow times, initial shock rhythm. If they have ROS before it's getting to the hospital, that's gonna be great. And having defibrillators available at public sites. So briefly into the treatments of cardiac arrest, we know we have the different chains of command, again, the labor rescuers, EMS, ED, cath lab, and ICU being heavily involved in this process. So BLS, again, we had a whole episode prior looking at the importance of high quality CPR. And again, chest compressions are associated with increased survival to hospital discharge. And this is something that I think most of us see and we need to speak up on. It's not interrupting CPR for vascular access, drug delivery, or advanced air replacement. That's something that happens quite often. And I have to constantly remind my providers, hey, we've been off the chest for 10 seconds, 30 seconds. Sometimes they get off the chest for a longer period of time, and that's when I just start CPR myself. Defibrillation is going to be key as well, and ventilations, again, with one breath every 6 to 8 seconds. Chest compressions. This is the best graph that I show my residents and people who rotate with me. And I always want to mention what's the importance of CPR, of chest compression, because if you can understand the importance of chest compressions, you can really understand the importance of our drugs that we're using. So the initial component here, when you have this compressions or systole, is where we're going to have an increase in organ perfusion, your left ventricle, right ventricle, and aorta. That's going to be very key because you want to get this pressure high as possible so that when you have diastole or decompression, you can feel that those coronary arteries. And that's going to be the main thing that we're looking for as far as be able to feel those coronary arteries through the coronary sinus so you can be able to perfuse your heart. And then from that standpoint, be able to get yourself to potentially an organized rhythm or a shockable rhythm and get your patient back to Ross. So we mentioned before, again, push hard and fast, 2 inches deep, allow for complete chest recoil. And number to treat is again around 27, 36, depending on which study or which review article you're looking at. But again, this is relatively good as far as the number to treat. Defibrillations, again, only for shockable rhythms. But of course, we spoke before about it being associated with an increase in survival with a number needed to treat of 4. Again, 4 people is all that's needed to shock these people out of it. So we now are recommending the biphasic method of our defibrillators with the energy, again, from 120 to 200 joules. Again, most of the time, again, in some pharmacists they actually going to be the person who's taking care of the drugs and the defibrillator. I just go ahead and get myself to 150 to 200 and shock it at that standpoint. Most of my providers do not start at 120, but again, it's allowable in the guidelines. And if for monophasic, if you guys are using those, 360. So just revisiting the ACS guidelines, and you see across the board here, no matter after you get to the point where you're shocking these patients in a shock rhythm, or initially, the first thing you want to do is the first drug is going to be epinephrine. And that's really going to be the star of the show tonight, talking about epinephrine given every 3 to 5 minutes, where in asystole and PEA, you want to give it a little quicker and up front. And then in the shockable patients, again, you want to do everything you can to shock those patients first outside of or not delaying them getting shocked for drugs or anything else. So let's talk about vasopressors. We did a little background, but what's the purpose? And I think when we understand the purpose of this and we understand that, for me, when I talk to my learners, I say, hey, what we're trying to do is increase coronary perfusion pressure. Why? Because that's going to increase our chance of Ross. And how we know that is because when we found studies that show that you have a decrease in cerebral perfusion pressure less than 15, you have a decreased chance of Ross. So you really want to do your best to get there. And the agents that's been studied over the years is going to be epinephrine, of course, but we've also seen phenylephrine, norepinephrine, and I think all of us are aware of vasopressin being utilized in cardiac arrest. So just bring us back to this famous chart here, looking at our vasopressor activity and noticing that the majority of them are going to have some alpha 1 or in vasopressin component V1 and V2 receptor activity. But again, the thing we're going to see is that across the board, there are certain drugs that have the same or a little higher amount of alpha affinity and increase in blood pressure. And that's the thing that we think is going to be the most prevalent when it comes to why these drugs work. But the cool part is, like, if we go back and look in the 80s, and I've went back again earliest 1906 to look at these original studies, and we found that people really got intriguing in the mid 1980s and 1990s, where we actually have studies looking at epi compared to phenylephrine. It was a RCT, again, a human study, again, only 65 patients, but again, we're not going to have anything huge in cardiac arrest. And I was surprised to find they had no difference in successful resuscitation, bradycardia, or hypertension. That's something I thought would be a slam dunk for epi, but it wasn't. And the study done in 1989 was an animal study. They looked at dopamine versus epi versus placebo, and the dosing ranged here using 45 mics per kilo and 2.5 milligrams per kilo for dopamine. Epi did see an increase in asphyxial arrest, but dopamine, interestingly enough, actually had an increase in ROS and patient VF arrest, which I thought was very unique due to the fact that there's some other studies done in sepsis and things of that nature that showed that dopamine had an increase in arrhythmia. So I really wouldn't have thought that we would be able to see that dopamine had increased ROS in those patients. Callahan in 1992 did an RCT in humans, and they did the big dosing of epi, 15 milligrams here compared to 1 milligram of epi. But then they also compared to norepi, which I thought was unique and intriguing. And they found that in those patients with the high dose epi, they had increased ROS and hospital discharge compared to the 1 milligram of epi. And then actually the norepi at 11 milligrams had an increase in ROS compared to the epi as well. Something that I really thought that we should have took more to. And there are some studies coming out recently in the post-arrest data saying that maybe norepi is a better pressor for those patients. But again, this is something that I really thought that they would drive home, 30 years ago and look more at the dosing of epi and cardiac arrest. But it's something that I think is going to come back around because my anesthesia colleagues are using a lot more push dose epi. I'm seeing norepi being utilized in a post-arrest component. So this is something that I really anticipate us seeing in the next 10 years, again, once people build up the courage enough to study something similar. In this last study that was done in 2008 with close to 3,000 patients, this is where we get a lot of our data for vasopressin. And it showed no major differences in this group. But again, there are some other studies showing that it potentially can be beneficial in a cocktail. But I won't dive really deep into that because I really want to focus just on the vasopressors today, and particularly focus more on epi. The next component, and I think this is where people get very intrigued, and I only had enough space for a few of these studies, and I really want to dive deeper into this today. But again, it's just so much out there on epi. If you go back to 1992, Brown and colleagues did a study, again, RCT, and this is where they had different doses of epi to 0.02 compared to 0.2, and that's going to be your standard dosing compared to your high dose mg per kg. And again, found no major difference in the things we care about: ROS, admissions, and discharge. And in 1995, another study was done looking at epi 1 milligram compared to 5, and again, no major difference in all those same exact things that we saw. 2018, they did 0.5 or half dose compared to 1, no major difference. And just continue looking across the board, we saw that these higher doses, again, was shown in this study to have an increase in ROS in hospital discharge compared to 1 milligram. But again, across the board, it wasn't much. And in the late 19, and there's like 3 more studies I want to put on here, but they actually found some associations with a decrease in patients that left with good neurological outcomes. And that's why the high dose was kind of X'd out. But I'm actually intrigued that we didn't really dive deeper into these lower doses or these weight-based dosing that, again, we utilize in pediatrics, but it's something that I'm intrigued with. And I wonder if lower dosing would get us the same amount of ROS, but not a major increase in patients that leave brain dead, so to say. So I'm intrigued with that component. That's something that I'm going to probably spend a good bit of my time trying to answer in my career, figuring out the right dose, or if we should even just be using infusions during this time and figuring out if there's some markers we can titrate to, if our physician colleagues can get us the access that we need.